Welcome to my channel. So today's topic of the video is severely elevated BP. In the previous video, I covered in the part one of the hypertension, I covered the hypertension management and the antihypertensive drugs. In this video, we are going to do the severely elevated BP, in which we have severely elevated BP without symptoms. Then we have the hypertensive urgency and hypertensive emergency. It is a very important topic and a very high yield emergency topic that everyone should know, and AMC loves to test this. So we have severely elevated BP. First of all, severely elevated BP is actually simply the elevated BP of 180 by 110, or it can be more, but it is without symptoms. That is, the headache or dizziness or end organ dysfunction is not present in this case. So time frame for initial BP reduction is 1 to 2 days, and it is managed in the primary care and follow up in days. It is on follow up in days. On the other hand, we have hypertensive urgency. Hypertensive urgency is the blood pressure of 180 by 110 or higher. So the blood pressure in severely elevated BP and hypertensive urgency is 180 by 110, or it can be higher. But in the case of urgency, there are symptoms present. The symptoms can be headache, dizziness, and there is moderate non-acute damage may be present. So if the acute organ damage is present, it would be hypertensive emergency. But if the moderate non-acute damage can be there in hypertensive urgency. So the target of BP reduction is actually in hours, and we have the target of below 180, and it is managed in the emergency department. Then we have the hypertensive emergency. So hypertensive emergency is considered when the blood pressure is 220 by 140 or it is more, and there is significant acute and organ dysfunction present. That is acute kidney failure, encephalopathy, papilledema, and other organ dysfunctions. So it is the immediate threat to life, and the BP reduction is actually targeted in minutes. BP reduction is in minutes, and we have to lower the BP more than 25% in the first 2 hours. So intravenous management is required in the cases of hypertensive emergency and its complication. I will cover these complications in the later part of the video. So first of all, carrying out with the management. The management of severely elevated BP starts with that. First of all, we have to check if the patient who already takes the BP lowering drugs and did not take his regular dose. First, we have to make sure that he takes the regular first. First he have to take that missed dose. Now, who the patients who do not take the antihypertensive and who are not on antihypertensive therapy, we have to first observe the patient with repeated measurements of the blood pressure to see if BP settles without intervention. And we have to consider starting and adding new therapy with standard drugs if not correcting. So in case of severely elevated BP is managed with the regular antihypertensive drugs. If the patient has missed his dose and he has not taken his BP lowering drug, he have to take it first. And if there's the patient who do not take antihypertensive drugs, so we are going to start him with the regular antihypertensive drugs. And first we are going to check that the BP settles without intervention, but if it does not settle, we are going to start our standard therapy. So if the blood pressure is not corrected and persistent or presence of risk factors are there for hypertensive complications, we have to consider investigation. For example, echo, chest x-ray, urinalysis, liver biochemistry, kidney function test to detect any end organ damage. If the blood pressure is not corrected and it is persistent, and also if there are other risk factors present. For example, the patient has diabetes or cardiovascular disease or any other risk factors. And if the severely elevated BP is in the presence of pain, the first line therapy would be analgesia, because as the pain is a very common triggering factor for the raised BP. So the pain can cause our high BP. So that's why if the patient is in pain, we have first line therapy would be analgesia in the case of severely elevated BP. Now we have the hypertensive urgency. So the management would be referred to the hospital to investigate for an organ dysfunction. And first, we have to make sure that the patient takes the regular dose of the missed antihypertensive drug. And if he is not on regular drugs, we have to give amlodipine orally single dose. It has actually the delayed onset, and we do not give repeated doses over short time. So, if the patient who is the one who requires rapid reduction in deep BP, that is, the patient has severe symptoms or risk factors for complications, we are going to give the drug that reduce the blood pressure within 2 to 3 hours. That is captopril, clonidine, or prazosin. So, the amlodipine is delayed onset and it decreases the BP in some time, but these drugs are considered when the BP reduction is required rapidly. And if the patient is the one who is not unable to take oral drugs, we are going to give the transdermal glycerol trinitrate or IV hydralazine. So the symptoms resolve and BP is less than 160. We have to send the patient home, and follow up is required the next day. While in case of severely elevated BP, the follow-up was in days, and in the case of urgency, the follow-up is in next day. And if the symptoms are severe and ongoing, we are going to refer to specialized hypertension clinic. Now we have the hypertensive emergency. We have to immediately transport the patient to hospital by ambulance, insertion of arterial line for invasive BP monitoring, or check BP every 5 minutes if arterial line cannot be inserted. So initial BP target is advised we have to take advice from the senior clinician. Drug of choice would be the one with rapid onset and short duration of action. The drug with the rapid onset and short duration of action. IV infusion is not immediately available. If the IV infusion is not immediately available, we are going to give the intermittent IV doses of hydralazine or clonidine or metoprolol. So intermittent IV doses can be given with these drugs, and if the IV infusion is practical and IV infusion can be given, the drugs would be sodium nitroprusside. It reduces the BP within minutes, and it requires intensive monitoring, and it is avoided in pregnancy and severe renal or liver impairment. Another drug that can be given with IV infusion are esmolol, glycerol trinitrate, and labetalol. So these are the drugs for IV infusion, and these are the drugs for intermittent IV doses. Now, if the target BP is not achieved, we have to take the specialist advice. There are some conditions that are associated with hypertensive emergencies in the ETG guidelines, that are acute pulmonary edema in susceptible patients with the increased hypertension. With the hypertensive emergency, the patient can have acute pulmonary edema, but in the susceptible patients who have severe or poorly controlled heart failure, and the management would be IV glycerol trinitrate or sodium nitroprusside. Adrenergic crisis, and these are most commonly due to the stimulant use, example cocaine or pheochromocytoma. Can be the cause of adrenergic crisis, and management in the case of adrenergic crisis would be phentolamine, and we have to consider hydralazine until phentolamine gets available. So phentolamine is not available easily, so first of all we have to consider hydralazine if it does not if while it is getting available. And if the patient is anxious, we have to give benzodiazepine as an adjunct. Beta blocker is contraindicated in the case of adrenergic crisis because it can cause extreme high BP. Then we have the aortic dissection. Aortic dissection is most likely when the heart rate is increased simultaneously with the raised BP. And management would be adequate analgesia because the patient is in severe chest pain, and we have to give the IV infusion of beta blockers. Say esmolol is the safest and it has the short duration of action. But if the heart rate is less than 60, in the case of aortic dissection, we have to give the IV infusion sodium nitroprusside or glycerol trinitrate. Then we have the stroke. Stroke is of two kinds: ischemic stroke and hemorrhagic stroke. In the case of ischemic stroke, stroke can be the complication of severely elevated BP, hypertensive emergency. So, in case of ischemic stroke, we have to avoid aggressive BP reduction. And in the case of hemorrhagic stroke, especially if the patient is on anticoagulant and antiplatelet, we have to urgently reduce the BP, and we can lower it up to about 140 systolic. Now we have the baroreflex dysfunction and autonomic dysreflexia. Autonomic dysreflexia is actually suspected when there are large fluctuations in the blood pressure and the patient has a history of spinal injuries. And if the patient has a spinal injury, he can have the urinary retention. And if there is catheter blockage, constipation, UTI, and pressure sore, these can act as the noxious stimulus to cause the autonomic dysfunction, and as a result it can cause the large fluctuations in the bb. So management would be first line management would be to treat the stimulus, and if the stimulus gets treated, the fluctuations in the bp would be corrected. Then we have the baroreceptor dysfunction. It is actually the acute severe hypertension of more than 250 blood pressure, and it is in the recent history of carotid artery stenosis, neck trauma, or neck irradiation. So if there is the history of this and the patient has acute severe hypertension, we are going to suspect the baroreceptor dysfunction. Then we have pregnancy and increased BP. It is considered we have to give the urgent treatment when the blood pressure is more than 170, and drugs recommended in pregnancy are hydralazine, IV labetalol, and diazoxide. So in the starting of the video, when we covered the severely elevated BP, I mentioned that there are certain risk factors that increase the risk of complications. So these are the factors that increase the risk of complications in severely elevated BP: extreme blood pressure of more than 280, coagulopathy, anticoagulant, or the patient is on anticoagulant or platelet therapy. He has undergone recent thrombolytic therapy, previous or current left ventricular dysfunction, left ventricular failure, kidney impairment, aortic or internal carotid aneurysm, aortic dissection, and pregnancy, recent vascular surgical procedures that required BP control. So that's it for the severely elevated BP and hypertensive urgency and emergency. I have covered all that was written in the ETG guidelines about this topic. Hope you like my video. Kindly share and subscribe the channel. Thank you.